This is Listen St. Louis with Carol Daniel. When I think about the critical issues facing Black and Brown residents in the St. Louis area, I often ask the questions: how did we get here? What's holding us back? And how do we progress? At 9 PBS, we want to deepen our understanding and change the narrative. Join me as I look for answers and discover solutions on today's podcast. It's the kind of news no family wants to hear. But my family, like far too many African Americans, heard the words dementia. My mother was diagnosed around 2017. Blacks who are older are twice as likely as older whites to have Alzheimer's, the most commonly known form of dementia. Today on Listen St. Louis with Carol Daniel, we talk to a neurologist and researcher to try to find out why that is the case, the role bias in healthcare may play, and why she says researchers need more diversity in their studies of Alzheimer's. That's today on Listen St. Louis with Carol Daniel.
Listen St. Louis with Carol Daniel is supported in part by Midwest Bank Center, the Betsy and Thomas Patterson Foundation, and Orvin and Latrice Kimbrough.
Welcome to another episode of Listen St. Louis with Carol Daniel. We thank you so much for tuning in to this episode and to all of our previous episodes. I think we're number 23 today. I am so proud to say that. So you've made it successful by sharing, by subscribing, by liking, by downloading. You download, you save it, you watch it later. And I want to go back to sharing because that is one way that we build the audience and share this conversation. We at 9 PBS want to change the narrative, and that is the story we tell ourselves about ourselves in the St. Louis region. So at Listen St. Louis with Carol Daniel, we are answering a couple of core questions. One is, how did we get here? And the other is, what can we do to progress? There is a third question: what or who is holding us back? Now, today's conversation is a personal one for me, as my mother is living with dementia. 7 years ago, she was diagnosed, and we have been in the struggle, in the battle, on the front lines since then. I've learned so much about it, and I have learned that more women than men, and that the number of African Americans who have dementia or Alzheimer's, the percentage is startling. It is far too high. So why is that? What can we do about it? Where do we need to stand in terms of research and our involvement in research? Diversity matters in research. We'll explain that as well. Joining me is a woman on a mission. She is Dr. Joy Balls-Berry, Associate Professor of Neurology. She is the inaugural lead at the Health Disparities and Equity Care at the Knight Alzheimer's Disease Research Center and Associate Lead at Precision Health in the Institute for Clinical and Translational Science at Washington University in St. Louis. That is a mouthful, my friend.
Hello, Carol. Thank you again.
It's so good to see. We've been on a couple of panels together, so I am aware of your work and of the powerhouse that you are, even though we're both like petite women, 5'4" and under.
I lie and say I'm 5 even.
I appreciate it. So let's start with the definition. What is dementia?
So dementia is an umbrella term that is used for a variety of different diseases and symptoms. It relates directly to our cognitive health, memory, and thinking. It relates to certain proteins that are processed in our bodies. It relates to plaque buildup in different types. So we think of frontotemporal dementia, which deals with the frontal cortex, or that frontal area of our brain. Alzheimer's disease is a type of dementia. There's Lewy body disease, which is another type. And there's even types of dementia that are linked to like vascular disease, like cardiovascular disease and endocrine disease. And there's even types that are linked to other diagnoses like Parkinson's disease related dementia.
And so you often hear, we're all just saying Alzheimer's, but that's just one form.
That's just one type. So, so if you take a umbrella And then you have the raindrops. So you think of Alzheimer's disease as one of those raindrops that's hitting the umbrella.
The Alzheimer's Association says older Black Americans are twice as likely as older whites to have Alzheimer's or another dementia. Research has not yet identified the cause.
That is true. Yes, African Americans are twice as likely as our white counterparts to be diagnosed. Hispanics are 1.5 times more likely to be diagnosed. And we think about our community here in St. Louis. If we take the numbers from a few years ago, the census numbers from African Americans, and let's say it's 240,000 people or so, and my numbers might be a little bit off, then that would mean about 10% are usually newly diagnosed per year. That means 24,000 people in St. Louis could be diagnosed with some form of dementia, likely Alzheimer's disease. It's the most readily diagnosed of the different types of dementia.
Are we diagnosed later?
We are. And I think that goes back to health disparities. I think that goes back to social and structural and systemic racism. I think that it goes back to access to care and the quality of the health care that we receive. It goes back to us being listened to when we know that there's a change in our memory and thinking. It goes back to our ability to receive care and memory and aging clinics from a neurologist, not just at the primary care setting. It goes back to the training that primary care providers and physician extenders have on cognitive health, especially in how we talk about our symptoms and what that means for us culturally. We can look. I'm from St. Louis. I grew up here. You know the people that I come from as well, and I think about the closures of hospitals in certain communities. Right. I think about the closure of clinics, and now we're in a time where new clinics are now opening, but do those clinics have an ability to refer to neurology? And is there a wait period? Are there enough neurologists? You know, we know with COVID, people have left healthcare.
Right.
And what has that impact been on brain health? What has that impact been on other types of health? And then also thinking about prevention. We don't know all of the things that we need to do for prevention. We know it's good to have more of a plant-forward diet. We know that, and that's for all health conditions, from cancer to hypertension to diabetes. We know lower sugar intakes. We know that we need to watch when and how we eat and what we eat. We know exercise is important, but we also know that theoretically that some of those symptoms with brain health changes happen 20 years prior to diagnosis.
Really?
But do we know what those symptoms might be?
So how do we know that it's 20 years prior?
Some people, they're studying it now.
Okay, so we look at the brain and we know.
And you can see whether or not it was long-term, but that's not done usually until autopsy.
Until death. Okay. Yeah. The Alzheimer's Association also noted that higher rates, and this is what you're touching upon, of cardiovascular disease may play a role in the prevalence of Alzheimer's among Black people.
Right, and because there's a type of dementia called vascular dementia, which is linked,
I've never heard of that one until today.
Which is linked directly to vascular health, and vascular health is linked to cardiovascular health and endocrine health. So think hypertension and diabetes. And we know what some of those risk factors are for that. Diet, exercise, stress management, and all of those things. And then we also have to really think in context with stress management and experiences of historical discrimination and how that may play a role in increasing our risk factors for vascular disease. If you live every day with chronic stress because you're not believed, because you're not listened to, because you are discriminated against, that can impact your overall health. That can impact increased risk factors for different cardiovascular disease, which means the risk factors for cancer goes up. The impact for heart disease goes up. The risk factors for dementia increase by not thinking about those structural vulnerabilities and those systemic discriminations that can impact our health.
But what we hear as well is the phrase lifestyle choices. And lifestyle to me sounds like I'm one who loves to vacation. I'm one who loves to go to the library. I love to go to jazz concerts. That's lifestyle. And then choice means that I made a choice. And so that puts the onus on the person. And so society at large and the medical community may be looking at the ethnic group and saying, these are choices you are making without the broader picture.
Exactly. And I think we need to look at that broader picture. We need to look at, like, I remember growing up in the city of St. Louis when the Delmar Divide happened. I remember it was right before I got my driver's license. And I remember when barricades were put up with pretty flowers. I remember that. And growing up south of Delmar in a community that is seen as being more privileged and being in the same zip code as my grandparents who lived north of Delmar off of Page, same zip code, different ward, same zip code. Instead of us taking 5 minutes to get to my grandparents' house, it now took 15, which meant that it also took longer for them to get to the hospital. So we think about that and we say, okay, well, that's lifestyle choice. Is it?
Right.
You know, part of
that was structure put in place
that was structural.
to divide.
That was structural. That was systemic.
Not to mention that it caused property values to change.
To change.
And
exactly.
that was the result of structure.
Exactly.
Policy.
Exactly. And then we think about the hospital that was right in that corridor in the Central West End and the West End for those that did not receive care within BJC or Deaconess when it existed. They would go to St. Louis Regional Hospital. That was now on Delmar, but north of that divide. And so we think about, and then eventually it closed. When, you know, St. Louis Connect Care and all the other things that happened, which meant that community was without a hospital.
I don't know that we still can wrap our brains around what was done, who did it, and the result of it.
Right. We can't. I think that there are a variety of things. I think politics played a role. I think laws play a role that were impacted, that people didn't think what the impact would be on some of those laws. I think that redlining played a huge role.
Huge role.
I also, and that is not health behavior. I do think that we do have some things that we can do for our behaviors, you know, that are related to our health. But I also think that if you go to the grocery store and and you have a family of 5 and it's cheaper to buy chips than it is to buy grapes, there's a problem.
Right.
And so we have to think about the wholeness of what health looks like and the wholeness of accessing health. It's not just talking to our physician or physician extenders like nurse practitioners and physician assistants and other members on that care team. It's also thinking about the grocery stores that are in our neighborhoods.
Or the ones that aren't.
Or the ones that aren't. It's also thinking about the, you know, what does the church what role does the church play into this? What role do other faith communities or non-faith communities play a role? What role does the mosque play? How can they leverage their powers in a way to help make change in those communities in which they exist? But then it's also, are we believed when we want to make change? And I think about my hometown and the changes that I've seen happen here. I think about the families that were displaced that were neighbors. I think about how my grandmothers in the 40s had to have their babies in different places. My mom was able to have my mother's mom, my maternal grandmother, was allowed to have her babies in Barnes Hospital. But my dad's mom wasn't, and she could pass for white.
But
But
did she have to go to Homer G then?
she went to City Hospital and had all her babies at City Hospital.
Okay.
I can't remember if it was City Hospital number 1 or number 2. And
So I certainly hear you describing, I mean, this is historic. And it's like building a wall and laying a row of bricks and then another row of bricks.
on top of it.
On top of it. And next thing you know, there is a wall, right? there is also a gender difference, is there not? More women than men.
I think that sometimes with women, I even think about my own journey, and I think about my journey as a caregiver. My mom recently passed in November, and I think we got lucky with her care, but I work in the system, right? Prior to me moving back home, she would talk about some of the things that were going on with her health. And I don't know if everything translated with the team that she had before I moved back home. In terms of thinking about the specialty care that she needed. And if I was not advocating for her,
She wouldn't have gotten it.
I don't think that she would have. And she would not have lived as long as she did, healthier. I can't do anything for dialysis because she eventually was on dialysis and things like that. But what we were able to do is ask questions. So part of what I really want to do in this community is teaching people how to have those conversations with their physicians, and that we are empowered, and that you can ask for specialty care. You can ask, okay, well, doc, I've lost this amount of weight, or I've gained this amount of weight. Who do I need to talk to? Maybe it's an endocrinologist. Well, what does endocrinology do? And it's increasing that health literacy
Right.
on the patient side so that they are empowered.
Because I'm sitting here thinking that the average person, the average St. Louisan, is going to wait for their doctor to recommend specialty care. That has to come from the doctor because insurance says and it does.
Right. The
have to
insurance-
come from
yep.
the doctor, but you can ask for it.
Right. Well, and the other piece too is giving the physicians the place to be able to ask for the care.
Do they not have the place now?
I think that they don't have as much time with patients as they did before.
No, certainly not.
So-
I made an appointment recently and she had 15-minute increments.
Yep.
15-minute increments.
And how much can you say in 15 minutes?
Not enough. I wonder, too, regarding dementia and all forms of dementia in the Black community. I remember reading a story about diagnosis, and there's this sense still that, grandma's just
Getting old.
How many times has she or he repeated, they always repeat stories.
Oh, you hear it all the time.
You hear it all the time.
Yep.
At what point, talk symptoms, at what point should we be pushing Mom, Dad, Mimi, Gigi, Paw, at
Nana.
what point, Nana?
All the things. I think once we notice that they seem to have a little more stress, when we notice that they seem like they're forgetting a little bit more, when we notice that if there's anything that seems off, anything, even if it's minute, like with my mom, when we noticed, and she had a diagnosis of mild cognitive impairment at one point, and it was linked to her vascular disease because she also lived with vascular disease, like she had congestive heart failure and a blocked carotid, a whole bunch of other stuff. And one of the things that I noticed was that she lost a whole bunch of weight. She lost 40 pounds at the beginning of the pandemic. I was living in Minnesota. My girlfriends here in St. Louis were going and checking on her because she didn't drive anymore, and they were taking food to her at the house, and she was not eating like she should. So there was something going on.
That's out of the ordinary.
That was out of the norm. And my mom loved food. And so when I came to get her, I was like, we need to talk to the doctor.
Was she resistant?
At first, because she didn't want me to step in because she's still the mama.
Sure. There's that.
And she told me, I'm still the mama. And I was like, yeah, you might still be the mama, but right now, let me do this for you.
And there is a shift that I wasn't prepared for that takes place where they raised you, now you raise them.
Oh, yeah. And it's different.
Yeah. And it's hard.
And it is so hard. Oh, my God. It is so hard. And I don't know if people think about the caregiver.
Enough. The caregiver doesn't think about the caregiver.
Oh, no. Mm-mm. After my mom died, I ended up in the ER.
Did you really? So let me say, I have a tissue here, because even before the cameras were rolling, we weren't recording yet. The doctor asked me, what was your question?
I asked if how are you taking care of yourself?
How are you taking care of yourself? And that was 40 minutes ago, and I have yet to answer the question.
Sure didn't answer
and I
me.
have this tissue because it is very emotional. Speaking of caregivers, and I don't forget about symptoms when something is out of the ordinary. And I will make the point that we did not know for 6 months because my mother and father hid it.
Yep.
And they lived in a different community. They hid it. We eventually find out because she had an episode. We find out that she had been she would do swim aerobics. She would drive to the indoor pool, and she would forget. She would sit in the car because she couldn't remember, now why am I here? And she would sit there until the memory came back, and it would take longer and longer, like 30 minutes. She never got lost, but she was lost, and that was happening.
In that moment, yeah.
And then the other thing that will get many of you is that they will cook, put a pot on the stove, and forget about it.
My mother was doing that too.
Yeah. My father said he came home and the house would be filled with smoke more than once. And they didn't tell us anything.
Yeah. My mom, this is pre-pandemic, she called me, and because she also had epilepsy. So we don't know if,
Right.
And so she called me on the phone. This was probably about 2018 or so. And she was like, I was boiling some eggs and I forgot they were on. And I was like, really? And she taught family and consumer science at Sumner High School for almost 40 years. So boiling eggs was not a hard task for her.
Right.
And she said, I don't know. She's like, I don't know if I fell asleep or I lost track of time. She was like, but something's off.
She told you that?
Yeah. And so what she started doing was, and that might have been 2016. That might have been right after Daddy died. Thinking back in my memory.
That's all right. No, no.
It happened.
That is a question I want to ask you.
And she said, I'm going to use my kitchen timer. So she started taking the old school white kitchen timer.
Right. Turn the knob.
Turn the knob. And then she also had some issues with her hearing since birth.
Were you worried when you heard that?
I was worried, and I said, what do you need? And I was, at the time, on faculty at Mayo Clinic. I was like, do you think you might have had, because my first thought was the epilepsy.
Okay.
Which is fair, right?
Right.
And so I was like, well, maybe you need to go talk to your neurologist. And luckily for us, she had a neurologist because she lived with epilepsy. But
now, the average one, my mother did not have a neurologist.
Exactly. Most people don't.
Right.
Most people don't. But my dad was also in the health field. So she had people advocating for her from the beginning. That's blessings and luck and favor.
And it's rare. So
exactly.
For most people listening, they don't have that. Mm-hmm. So we go back to your advice to ask for a specialist.
Exactly. Say, look, I don't feel like myself. I'm having more stress. I've got this going on at home. I'm forgetting things. Whatever it might be that is not the norm, tell your healthcare provider.
However, we're saying all of this in an atmosphere where maybe we have a little more trust, but we don't have enough trust.
Exactly. Because we also know,
as Black people,
that part, even especially as I think about the research that I do in my lab, when we think about discordant, and I live every day with dyslexia, so if I misspeak, just know that this is a dyslexic conversation.
You are yet a doctor and a researcher, so yeah.
So I call it my superpower.
You're right.
So we think about the discordant care. We think about who is giving us care.
And what is and describe discordant care is?
Like thinking about the people that we receive care from.
Okay.
Do they look like us? Are they culturally aware of who we are? Do they come from our community? And if they don't, do they have enough cultural intelligence to be open to how we present symptoms?
Right.
And thinking about, well, mama's forgot something, or dad's forgot something, or Nana, we went to church and Nana forgot. She wears gloves and stockings every time we go to church. She didn't have on stockings. Is that a problem? That's not her norm.
Right.
What is going on with the norms? The other piece is, I think culturally as an African American, and I lead with my Blackness and my womanness and all of those things. I
Amen.
think that, and as I should, right? But I also know that in my own health journey, there were times when I was not believed when I talked to a physician, provider about my own symptoms. And that's now impacted other things in my life. And so I think that also teaching the next generation of physician, like those in medical school or nursing school or PT or OT, whatever the avenue of care, those on the care team, the ability to have cross-cultural communication.
And this is not a conversation about diversity, equity, and inclusion.
No, it's not.
It's not, but and yet it is.
Exactly.
And I know, we all know there's a battle in the country, and some are being successful in eliminating DEI positions and teaching, education, seminars, and yet these problems are statistically real.
Exactly. So I look at it like this. I think that diversity is going to happen, regardless to whether or not laws change. Because as we grow as a community, we become more diverse. Baby boomers have had more babies, and there are more couples out here who are from different parts of the world, who are ethnically and racially diverse, who are diverse related to spirituality and religion. Diversity is going to happen. Equity is when I am brought to the table, do I have voice? Mm-hmm. And am I heard? And inclusion is whether or not I have a voice and am I heard. And equity is listening to me and then making sure that my needs are met or helping me figure out how to meet those needs. That's equity. I think about it like this.
And that doesn't mean that we're taking anything from anybody else.
We're not taking anything from anyone else, but we're making sure that everyone has what they need for wellness.
Because wouldn't we want, as a country, everybody to be healthy?
Exactly.
And right now we know that everybody is not healthy.
No. And we can map that with GIS mapping. That's not my area of expertise. But those that do mapping, they can map where more poor and good health outcomes and poor health outcomes based on zip code, which is environment. They can look at it in terms of census block.
Down to.
Yeah.
Down to. And I will, the other part of that from the Alzheimer's Association research, that if we correct for overall health and socioeconomic status, the differences disappear. In other words,
some of them do, yeah.
If we can improve socioeconomic status, home, environment, access, education levels, all of that, those differences disappear. I do want to ask you, in addition, that when you talk about the studies that you are doing, talk about why we need diversity in study participants. That is a great push, not only at Washington University, but around the country.
Well, even globally. So we think about the new meds that have come out for Alzheimer's disease, and some of them are very promising. Like diseases that are looking at early diagnosis of Alzheimer's and what those can do. But when we dive into some of the clinical trial data and we look at the number of participants, where they live geographically, and then their socioeconomic status, that makes an impact. So, for instance, Aduhelm was a drug that has since been pulled from market.
Right.
And when the clinical trial happened, there were a little over 3,000 people. About 19 to 20 of them were people of color. When the drug went to market, it was $50K a year, $50,000.
Wow.
Over 50. It was like 56, 58, but it was a lot of money. And that was just the medicine. That didn't include the monitoring, which were imaging, so like MRI scans and other scans, the biomarker tests, so like blood draws, things like that, and then the fact that the medication had to be administered in an infusion center, like where someone would go for cancer treatments, and then the patient also had to take someone with them.
Okay.
So you've got a lot. It's expensive. So they said, "Oh, we're gonna reduce the price."
To what? 40,000?
It ended up being like 20 something thousand. But we didn't know if it worked in communities who self-identified as communities of color, or those communities where there were lower socioeconomics, because the studies weren't being done in those communities. So in science, we talk about generalizability, which means that if we repeat the study, we will get the same findings every time. Mm-hmm. We also have to think about that in terms of drug development and device development. If the people that need the device the most aren't in part of the trial, then how do we know that the medicine is going to work? We know that blacks are twice as likely to be diagnosed, and African Americans, so those across the African diaspora, are twice as likely to be diagnosed with Alzheimer's disease. But yet,
you're not researching African Americans.
We're not working with those communities. We're not oversampling those communities. We're not talking to those communities about what if we develop the bench scientists, those who do patient-centered outcomes research, the clinical trialists, if they have the ability and the desire to be more community forward and community engaged and patient-centered, then I think that those trials would be designed very differently. And that's some of the work we do in my lab.
Now, and is this about differences in us, the difference between us, between Black people and Europeans, or is this about delivery, acceptability, access?
I think it's more about acceptability, access. I think it's about biases. I think it goes back to trust. I think it goes back to, like, we were doing these brain health conversations. I call them brain aging cafes. And it was listening sessions, so basically like a community need assessment. And to ask, well, if we want to do research on dementia in St. Louis, what does it need to look like? And we talked to over 300 people, 306 people to be exact, more women than men. So we need to figure out how to get guys involved. But the thing that I've noticed was that the untreated syphilis experiment in the Negro male came up, which we sometimes call within the culture the syphilis experiment.
Right.
I mean, the Tuskegee experiment. The Cold War experiments that happened in St. Louis and downtown St. Louis and the Black and poor white communities, that came up. The issue that healthcare providers that they go to are not providers of color, or for women, not women providers. All of those things came up. And so it then goes back to, who are we as academic medical centers and big pharma, who's doing those studies? The people conducting those studies, the principal investigators, the leads of those studies, are they rising up from the community? Which goes back to creating pathway programs.
So the answer to that is no.
They're
generally no.
Generally no, I think, in some ways. I do think that there are some really good pathway programs that are being started.
But are you saying that we need diversity in the studies, in the research, and we could get more if we had more researchers who look like us?
Definitely. Because I noticed that when I go out and talk to the community as a Black woman scientist, and I bring another woman of color with me, the conversation is very different than when I bring a colleague of mine who is not from the community. There was a funny story. My mom, this is before my mom passed, she got sick. and she was home with my husband. And we know now that she probably had a mini stroke. And I had left, and she was staying at my house because she had just gotten out the hospital for something else. And my husband, I looked at her, I said, "Are you okay?" And she was like, "No, I'm fine." I was like, "Well, you haven't touched your breakfast." She's like, "I'm fine." She was like, "Go to the thing and tell everybody I said hello." And some of these people were folks, like Nell Cheatham and Fannie Bolin were there, and Stephanie and a couple other folks. And so my husband called me, and he said, "I am calling an ambulance because she's not okay." And I could not be there. And I'm thankful for my village. You asked me if I have a village. So I'm thankful for my village of community members that were there with my study team. And it went forward. Well, one of my research partners is from Canada, and she's white. And so she had to step in with a few members of the team to move the work forward. And someone said to her, they were like, "We know you're not Dr. Joy." She was like, "No, I'm Dr. Jessica, and I will fill in as best I can, but I ask for y'all to be just as honest with me as you are to her." And she was like, and I told them, I said, "Let them know that Mom's in the hospital," and to pray, because it was being conducted at a Black church here in town. And with that church, they helped us design what we were doing that day and all of that. And I'm thankful that she acknowledged her privilege. I'm thankful that the community trusted her enough to be forthcoming. But that doesn't always happen.
No. So she said to the doctor.
Well, she said to the community, she was like, "Look, I do bioethics research. I'm not from this country, but I want to make sure that I honor and I listen.
Right.
And the only reason Joy isn't here is because she's at the ER with her mother." And
I see. So she went to speak in your stead.
yeah. And she was going to be there anyway because we do a lot of stuff together.
Yeah.
But I'm thankful for that. I'm thankful that the community trusted her because they didn't have to.
But she had to show up in a humble,
exactly,
culturally sensitive way.
Right. And that goes back to cultural intelligence, which is not DEI. That is recognizing the cultures that we represent and then the cultures of the people that we are conversating with or we're holding space with.
Someone said to me once that if we were to take out, ethnicity and just talk gender, like no one would debate that women don't face sexism in this country. That would not be a debate. It's not a debate.
Exactly.
It's not a debate. We know that as women, we are in danger, more in danger. But the debate over racism, that it's over, that you should get over it, that you can survive and succeed and thrive in spite of it. And while that may be true, I mean, I'm a testimony. I have a testimony to surviving and thriving despite what was thrown against me. That doesn't mean that what was thrown against me is a fiction of my imagination.
So my husband and I lived in Minnesota for about 8.5 years. And when we bought our first house, we bought it in the wintertime. And, winters in Minnesota can be brutal. So we're talking like 6 months. So once the spring came, I got really excited. And one of my girlfriends who's really into flowers decided to buy me some flowers for my front porch. She was like, "You get the pots, I'll bring the plants." So we worked outside in the yard, planted these flowers in these pots, and I do not have a green thumb.
Me neither.
At all. And she said, "I think I'm going to run and go pick something else up because you need some height." So she left and went to her house, which was about 15 minutes from where we were. During that time, I decided that I was going to get the broom and the water hose to clean up the potting soil. I'm not in the house maybe 10 minutes. I come out, and there's a decapitated bunny wrapping on my front lawn.
What?
As a welcome present. But yet racism does not exist. And then my husband found another one. And then fast forward a few years later, I'm walking down the street from my job to the parking lot, and I'm standing at the corner, and there's a cyclist next to me waiting to cross the street as well, and the traffic is pretty thick. Now, it's Rochester, Minnesota, so it's not like being in Minneapolis, which is a big city. Smaller city still, but not as big. And we're standing there. This car pulls over and stops and calls me the N-word. The cyclist, who was not a person of color, looks at me, and I said, did I just hear? She's like, oh, just let it go. I'm thinking to myself, let it go? So what did I do? I was like, well, you know what? I was walking to a lot that is for the person that I was employed by. And granted, it did not happen on property for the hospital. It still happened near the hospital. Mm-hmm. So I ran into the CAO. I tell you how God works. We just happened to be in the hallway. And I told him what happened. He said, what? There are now cameras on that corner. Mm. So he used his influence as the second in command at Mayo Clinic to make sure that we felt safe. That does not always happen. So I'm thankful for that ally. When we moved back home to St. Louis, I grew up in the Central West End, and my husband and I decided, this was July of 2020. Yeah. So we moved back. I started at WashU July 1st, 2020. So we're walking down the street. Everything's shut down because it's still, pandemic. And we decide that we're going to walk on the Lindell side of the street, not on the Forest Park side. Mm-hmm. I grew up on Lindell. My brother and I still own our family home. So people are asking, we're going to sell it? No, that is not the plan because we've been asked. And we're walking down the street and somebody passes us and yells the N-word. But yet we say racism isn't real. And yet these things impact us. Systemic discrimination impacts our cognitive health. It impacts our memory and thinking, chronic stress, all of those things.
Play a role. Mm-hmm. Play a role. And those are difficult, have proven to be. We've unpacked a lot. Yes, we are further along. Generally, I can live where I want to live. Generally, I thank God my husband is a veteran, so a VA loan. Mm-hmm. I wasn't in the open banking market because the Federal Reserve says, by the way, studied this, that despite income, despite down payment, despite credit rating, mm-hmm. all of those being the same, that African Americans are likely to pay a higher mortgage rate. Yep. And that's study's probably not 10 years old, but that's a current. To me, that's in our lifetime. That's current information. That's pretty current. And so those things impact
where you live.
And mm-hmm. so we have to, though, we want to not get it at all, mm-hmm. but we don't know enough.
No, we don't. So
and get it Alzheimer's.
Yeah, I knew where you were going, but I think that there's a beauty in the conversation we're having today. Maybe we'll inspire someone to ask their physician or their care team, do you know about any research studies where I can just talk to someone mm-hmm. that might not, that might be a starting place. In my lab at WashU, we are doing some projects now around, those types of conversations. We have a research registry, and we're looking for people that don't necessarily report changes in their memory.
So who?
For 40, those who are 40 and older.
Okay.
Who receive care within the BJC. Well, don't have to necessarily receive care in the BJC system or the WashU system, but they receive care within our community, in the bi-state mm-hmm, area. Mm-hmm. who we don't have a mile radius or things like that, because we do know people drive and fly into St. Louis or to Belleville or to Alton or Christian or wherever to receive care, but who are 40 and older who were interested in learning about brain health and are willing to give some of their time to do some surveys and to talk to us.
And we don't know that it is, do we know whether it's hereditary or not?
So there is a dominantly inherited form of Alzheimer's disease, and the expert on that in our community is a guy named Randy Bateman, and there's a network of them, but it is tiny, 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 like so small that it's only like a few families, and I can't remember how many it is, like 100 and something families. So we know that the types of Alzheimer's disease and dementia that are being and related dementias that are being diagnosed, we're not sure about all of the genetic factors. There is Carlos Conchaga at WashU is studying genomics in this space to look at other things and look at biomarkers and things like that. And that is not my area of expertise.
But is it not, I mean, is it true that the older we get, memory is going to fade?
The older we get, the higher the risk factor for developing dementia.
There will be some level of forgetfulness?
Possibly. But not for all. Like, I think about my grandmother and her sisters who were all in their 90s when they died. They were sharp as a tack.
My father, he didn't have it, but we wonder whether he was developing it as he was, because he was a caregiver, and the stress of that, we thought.
And that's what I'm wondering, which is like weathering.
Right,
like chronic stress.
Right.
Histories of discrimination. You said he was a vet. Imagine the things that he had to do serving our country so we didn't have to serve.
For sure, for sure. Is there a sense that my mother has dementia, should the adult children of anyone with dementia or Alzheimer's be in a...
Yes.
And certainly Black people?
Yes.
And why?
Because we don't know we don't know all the causes. We don't know all the risk factors. We don't know there are a lot of different things that could be studied on with genetics and precision medicine and all of that. And if we are not a part of those studies, then people will make assumptions about what we need as a community. And as people, in terms of Black people and women even, but we got to get men in too.
Right, and we talked about the higher rates of cardiovascular disease, high blood pressure, diabetes among African Americans. My mother had. We found out when she had a major stroke that she had 6 prior. We did not know, and they never found out. Because by this time she has dementia, so she couldn't tell you. Couldn't tell us, what happened. And so I've always wondered about that relationship between what stroke does to the brain and the presence of dementia.
It's interesting because I look at, I think about like some of the work that's being done in neurology and what are those risk factors for like stroke. For infarcts or mini strokes, and what is the correlation or the relationship to dementia, and I don't know how many studies have been done in that space, because those can be done looking at medical records without really even. I'm an epidemiologist, so I'm always thinking about those retrospective studies that we can do.
And is that an area of concern, of curiosity?
For me,
medical
it is.
Curiosity?
I think for some it is.
Yeah.
I do think that because we got to think about the overall risk factors, diet, exercise, the genetic factors that might lead to endocrine diseases like diabetes or hypertension and those gene markers. And I don't, and I often wonder, like, what are those bigger connections as well, and maybe that's the next grant.
Right. I had a researcher tell me, this is probably 5 years ago, that one drug was being studied, and he said, incidentally, we found that when women have a stress-related event, and when people have a stress-related event, cortisol levels, of course, increase. And he said to me that in men, after that event is over, cortisol levels return to normal.
Interesting.
But they found that the levels in women stay up, remain elevated. And he said it in such a casual way. And I said, well, is that going to be an area of study? He goes, we probably should look at that. Said those words. We probably should look at that. And I thought, you probably should look at that. So there's not enough women in studies. There's not enough diversity in studies.
There's not enough men in studies.
Not enough black men in studies.
Yep. So I remember my dad saying to me, my dad was my mom's caregiver. And like your dad, he passed. And I got to interview him and actually publish with him right before he died. And one of the quotes from that publication was, "Men think that they're okay and they're not."
Oh. Why am I thinking of my husband right now?
Or they'll say, and I was like, let's unpack that. What does that mean?
Right.
And he was like, I think I'm good. And do you know that paper came out January of 2015? That April he was diagnosed with. His best friend died, Ronald Bolin, like that spring. And then Daddy was diagnosed right after that with cancer. And it sticks out in my head to say, we've got to do something for our brothers. Because if they're not speaking up or they don't want to talk about changes.
Right.
Then
Who is? Who is?
And then if we say they're not partnered, married, or otherwise, then who's speaking up?
Who do they have
Yep.
in their corner?
Exactly. And
I think that to say that I'm good
and you're not good,
and you're not, I mean, that's just been where their lives have been as an American experience.
Exactly, because
I have to be.
I have to be good.
I have to be good.
I've got to be good. And if I'm not good, then everything else is not going to work.
Right.
Or I won't be believed.
I didn't know this conversation was going to be all philosophical. I should have known, knowing you. I should have known. So I want you to leave us with how can people become a part of the study? And we know that one of the impediments to getting diversity in studies, getting more African Americans in studies, a person might think, how much time do you need? And I'm already working 2 jobs and I already have, taking care of kids and grandkids. How much time is this going to require of me?
So for our co-equal study, which is a study to diversify medical research around Alzheimer's disease and brain health, and I chose the name co-equal because it relates to equity, inequality, and health. It's actually a word, right? Like one word. We are looking for people that are 40 and older that receive care within the St. Louis area or surrounding areas, who are willing to give a couple hours of their time 3 times a year.
Oh, a couple of hours 3 times a year?
Mm-hmm.
Okay.
That's not bad, is it?
That's not bad, because I think that the average person might think, first of all, you're going to stick me with needles. You want all my medical information. You want me there weekly. It's just going to take too much time. And that's not the case at all for your study.
For this particular study, we do ask that we have access to medical records so that we can look at some other things. But then the other big piece with the co-equal study is the fact that we are now asking you, hey, there might be other studies that might be doing biomarkers, that might be doing MRI screenings, that might be clinical trials. Can we connect you with the NIDADRC, Alzheimer's Disease Research Center, research studies that are also doing some of those other studies? So like, for instance, we talked about your mom living with Alzheimer's disease. There might be studies that relate to doing a blood draw or doing a lumbar puncture or doing some of those what they call biomarkers that are fluid-based or even imaging-based like MRI that tell us more. But then there are also studies like the ones that we're doing that just give us a chance to have a conversation, or that might be short questionnaires. And I think all of that builds trust because we do an education component within the work that we're doing. Okay, this study is this type of study, but we also have these others as well. And then we And then we're actually designing some other things to figure out how do we have those conversations for the studies that might be biomarker based, that culturally.
There are 5 of us siblings, and one of my brothers, people think I'm glasses half full, and I am an optimistic person, but he's more optimistic. He's more the glass is full. It may not really even be full, but he is so much more optimistic than I am even. And he, they're going to find a cure, and mom's going to be okay. And I'm not there. She's 88. She's 88. Yes, she's 88. And because of what we've seen, drugs being studied, drugs being pulled for Alzheimer's, I don't feel hopeless, but I don't think it's going to happen in her lifetime. How hopeful are you?
I am hopeful. I'm knocking on 50's door, and I'm hoping that we can diversify research in a way that we can find a cure before I hit 80.
Okay. For me too, then. Because I'm 62. So
we ain't far apart.
20 years.
So I'm hoping we can, but the only way that's going to happen is if the clinical trials and the observational studies have people that represent the communities that are most impacted by the disease.
Okay.
And if we're not there, then nothing's going to change.
All
and
right,
so we got to be hopeful that we can get people in the door.
Well, that's why I wanted you on.
Thank you.
To get people in the door. And if I can do a couple of surveys 3 times a week, I can do that.
Yeah, and it's only, I'm telling you, and then it connects you to other research if you want to do other stuff. That's that might be a little more time intensive, but guess what? That means our voice is heard.
Absolutely.
And it's for the next generation.
Thank you so much.
Thank you, Carol.
I didn't need my tissue. I thought I would.
I thought I was going to cry too.
Well, I thought we both were going to cry. We both have lost parents.
It doesn't mean it won't happen after we stop talking.
She is Dr. Joy Ballsbury, and she's the Associate Professor of Neurology and the inaugural lead, Health Disparities and Equity Core in the Knight Alzheimer's Disease Research Center and Associate Lead, Precision Health in the Institute for Clinical and Translational Science at Washington University here in St. Louis. Thank you so much for all of your, it felt like it was encouragement. It was all encouragement.
We have to be optimistic.
Thank you, thank you, thank you.
Thank you.
And thank you for joining us on another episode of Listen St. Louis with Carol Daniel. Don't forget to like, to share, to download, and to leave some comments. Let us know if there is a guest or a topic that you think we should cover on Listen St. Louis. We'll see you next week with another episode of Listen St. Louis with Carol Daniel. Thanks for joining us.
Listen St. Louis with Carol Daniel is supported in part by Midwest Bank Center, the Betsy and Thomas Patterson Foundation, and Orvin and Latrice Kimbrough.